patient matters.
ബഹുമാനപ്പെട്ട IMA വൈസ് പ്രസിഡന്റ് നിർമ്മൽ രാജ് സാർ, സീനിയർ നേതാക്കന്മാരെ, സഹപ്രവർത്തകരെ, IMAയുടെ കഴിഞ്ഞ ഒരു സമരം, 2 ദിവസത്തെ സമരവും അതിനുശേഷമുള്ള കാര്യങ്ങളൊക്കെ എല്ലാവർക്കും അറിയാമെന്ന് കരുതുന്നു. എന്തായാലും IMAയുടെ ഒരു കുറെ കാലത്തെ ആവശ്യമായ ഹോസ്പിറ്റൽ പ്രൊട്ടക്ഷൻ ആക്ട്, അതിൻ്റെ ഭേദഗതികളൊക്കെ കഴിഞ്ഞ മന്ത്രിസഭാ യോഗത്തിൽ പാസ്സാക്കിയതും അതിൻ്റെ ഓർഡിനൻസിൻ്റെ കാര്യങ്ങളൊക്കെ എല്ലാവർക്കും അറിയാമെന്ന് തോന്നുന്നു. ഞാൻ 1-2 കാര്യങ്ങൾ കുറച്ച് വായിക്കാം. അതിൽ പ്രധാനപ്പെട്ട കാര്യങ്ങൾ: ഒന്ന്, സ്പെഷ്യൽ കോർട്ട്, എല്ലാ ജില്ലകളിലും സ്പെഷ്യൽ കോർട്ട്, പിന്നെ സ്പെഷ്യൽ പ്രോസിക്യൂട്ടർ, 60 days by which police officer has to finish the enquiry, 1 year for the verdict, 7-year imprisonment, and apart from health workers, security and management staff also included, and there is special order for other safety measures. ആൻഡ് ഇതൊക്കെയാണ് പ്രധാനപ്പെട്ട കുറച്ച് പോയിന്റ്സ് അതിലുള്ളത്. ഇപ്പം ബില്ല് അടുത്ത ഈ വരുന്ന അസംബ്ലിയിൽ പാസ്സാക്കുമെന്നാണ് കരുതുന്നത്. അപ്പോൾ അതിനിപ്പം നിയമസഭയിൽ എങ്ങനെയാ അത് പാസ്സാക്കുമെന്നുള്ളതൊക്കെ നമുക്ക് കണ്ടറിയേണ്ടി വരും. MLA-മാരൊക്കെ അതിന് ഭേദഗതികൾ ഉണ്ടാവുന്ന കാര്യം അറിയില്ല. എങ്കിലും നമ്മുടെ ഈ ഹോസ്പിറ്റൽ പ്രൊട്ടക്ഷൻ ആക്ടിന്റെ അതുമായിട്ട് ബന്ധപ്പെട്ട IMAയുടെ സമരം ഒരു പ്രധാനപ്പെട്ട ഘട്ടത്തിലെത്തിയിട്ടുള്ള സമയമാണ് ഇപ്പോഴത്തെ. എന്നാൽ ആ സമരത്തിൽ പങ്കെടുത്ത എല്ലാവർക്കും അഭിവാദ്യങ്ങൾ. അതാ പറയാനുള്ളത്. പിന്നെ നമുക്കൊരു ഡോക്ടേഴ്സ് ഡേ സെലിബ്രേഷൻ്റെ സമയമാവാനായി. ജൂലൈ 1 നമുക്കപ്പോൾ കഴിഞ്ഞ പ്രാവശ്യമൊക്കെ വളരെ നന്നായിട്ട് നമ്മൾ നടത്തിയതാണ്. അപ്പോൾ അതിൻ്റെ തയ്യാറെടുപ്പുകൾ നമുക്കിപ്പോഴേ തുടങ്ങണം. വുമൻസ് വിങ്ങും ആർട്സ് കമ്മിറ്റിയിലും കൂടിയിട്ട് തുടങ്ങും. ഇത്രയാണ് അസോസിയേഷന്മാരിൽ ഇപ്പോൾ പറയാനുള്ളത്.
കഴിഞ്ഞ SWCയിൽ ഇതിനോട് ബന്ധപ്പെട്ടുകൊണ്ടുള്ള വളരെ വിശദമായ ചർച്ചകളും അഭിപ്രായങ്ങളും ഉണ്ടായിരുന്നു. തലശ്ശേരി വെച്ചായിരുന്നുണ്ടായിരുന്നത്. അതിലുണ്ടായൊരു വിഷയം, ഇതിപ്പോൾ നമ്മൾ സന്തോഷത്തോടു കൂടി കുറച്ച് കാര്യങ്ങളായി എന്ന് തോന്നുന്നുണ്ടെങ്കിലും ഇത് ഇനി MLA-മാർ ഒന്ന് ചർച്ച ചെയ്തിട്ട് ഇതൊന്ന് ലഘൂകരിക്കാനുള്ള ഒരു സാധ്യത ഉണ്ട് എന്ന് ഹെൽത്ത് മിനിസ്റ്റർ തന്നെ വിശദീകരിച്ചിട്ടുണ്ട്. അത് നമുക്കൊരു പാരയാകും എന്നുള്ള ഒരു അഭിപ്രായം മൊത്തത്തിലുണ്ട്. കാരണം എന്താണെന്ന് വെച്ചാൽ ഇപ്പൊ തന്നെ കുറെ നെഗറ്റീവ് കമന്റുകൾ സോഷ്യൽ മീഡിയയിലൊക്കെ ഇങ്ങനെ വരുന്നുണ്ട്. ആരെയും പിടിച്ചകത്താക്കാം, ഒരാള് ഇഞ്ചക്ഷൻ വെക്കുമ്പോൾ എന്ന് പറഞ്ഞാൽ അത് ഡോക്ടർക്കെതിരായി പോയി എന്നുള്ള രൂപത്തിലൊക്കെ ആകാം എന്നൊക്കെ ഉള്ളത്. അപ്പൊ നമ്മൾ സജഷൻ പറഞ്ഞിട്ടുണ്ട്, പറ്റുമെങ്കിൽ ഈ അടുത്ത നിയമസഭയുടെ മുമ്പ് ഈ നമ്മൾ ആദ്യം കണ്ടതുപോലെ നമ്മുടെ എല്ലാവരുടെയും MLA-മാരെ ഒന്നും കൂടി കണ്ട് ഇതിന്റെ പ്രാധാന്യവും മറ്റു കാര്യങ്ങളും ബോധ്യപ്പെടുത്തുന്ന നല്ലതാകും എന്നുള്ള ഒരു സജഷനും കൂടി വന്നിട്ടുണ്ട്. ചിലപ്പോൾ അതിന് നിർദ്ദേശങ്ങൾ നമുക്ക് വരും. പിന്നെ രണ്ടാമതുള്ള ഒരു വിഷയം, നമുക്ക് ഇപ്പൊ നമ്മുടെ സ്കീമുകൾക്കൊന്നും GST ഇല്ല, പക്ഷെ GST വേണം എന്നുള്ള ഒരു സജഷൻ വന്നിട്ടുണ്ട്. അപ്പൊ അതുകൊണ്ട് തന്നെ നമ്മൾ അതിനെതിരെ GST എക്സംപ്റ്റഡ് ആണ് എന്ന് പറഞ്ഞ് സുപ്രീം കോടതിയിൽ കേസ് കൊടുക്കുന്നുണ്ട് IMA KSB. എന്നാൽ കേസ് എങ്ങനെ ആകുമെന്ന് അറിയാത്തതുകൊണ്ട് 20% നമ്മൾ അഡീഷണൽ പേയ്മെന്റും കൂടി നമ്മൾ ഇനി മുതൽ സ്കീമിൽ വാങ്ങാൻ നിശ്ചയിച്ചിട്ടുണ്ട്. കാരണം 18% ആണ് GST വരിക. 20% വാങ്ങിയിട്ട് ബാക്കി 2% വേണമെങ്കിൽ തിരിച്ചു കൊടുക്കാം എന്നുള്ള രൂപത്തിൽ ഒരു സജഷനും കൂടി ഉണ്ട്. അപ്പൊ അതുകൊണ്ട് തന്നെ സ്കീമിൽ വില കൂടാൻ ഇപ്പൊ അടക്കുന്ന പൈസയിൽ നിന്ന് 20% സ്കീമിൽ കൂടും എന്നുള്ളത് എല്ലാവരും ഒന്ന് മനസ്സിലാക്കി വെക്കണം എന്നുള്ളതും കൂടി പറയണം. കുറെ എതിരഭിപ്രായങ്ങളും ഇതൊക്കെ കൂടെ വന്നിട്ടുണ്ട്. അത് നമുക്ക് അനുകൂലമായി കേസ് വിധി വന്നാൽ പൈസ തിരിച്ചു തരണം എന്നുള്ള സജഷൻസ് ഒക്കെ വന്നിട്ടുണ്ട്. അനുകൂലമൊന്നും അത്ര പെട്ടെന്നൊന്നും കിട്ടുന്ന കാര്യമൊന്നും ആയിക്കോണമെന്നില്ല. കാരണം നമുക്ക് മാത്രമല്ലല്ലോ എക്സംഷനെ. അപ്പോൾ അത് വിശദമായിട്ട് അത് നടക്കുന്നുണ്ട്. അപ്പോൾ ഇനി അടുത്ത അടവ് മുതൽ ഒരു 20% ഹൈക്ക് എല്ലാ സ്കീമിലും ഉണ്ടാകും എന്നുള്ള ഒരു ത്രട്ടല്ല, ഒരു നിർദ്ദേശം കൂടി അതിൽ ഉണ്ട് എന്ന് കൂടി എല്ലാ മെമ്പർമാരും ഓർമ്മിപ്പിക്കുകയാണ്.
Thank you, sir. Okay. Now, may I invite Dr. Latha to come to the dais? Introduction by Dr. Rakesh.
Good evening all. So it is said that by 2050, more people will be dying due to antimicrobial resistance than cancer. Okay. Why? Because not much companies are interested in rolling out new antibiotic. Because as soon as you release one antibiotic, immediately it will become resistant. The money is gone. Had they invested in diabetes, hypertension, that will be even more profitable. So less number of antibiotics are coming. And antimicrobial resistance is becoming a real global threat. So we have the apt person to speak on this, Dr. Latha, physician, District Hospital, Kannur. She did her MBBS from Adi Chuchangiri Institute of Medical Sciences, Bellur, and she completed her MD medicine from Government Medical College, Calicut. And she is joined health service in 2005, and she has maintained an excellent reputation as a physician in a district hospital, and it is her name is well known while in COVID times and all. And I welcome Dr. Latha to speak on this antimicrobial resistance.
Respected Vice President, Secretary, senior members and friends. So as already told by Dr. Rakesh, I'm speaking on antimicrobial resistance, a global threat. So this session today is just an insight into the problem of antimicrobial resistance. So it's not difficult to make microbes resistant to penicillin in the laboratory by exposing them to concentrations not sufficient to kill them. There is the danger that the ignorant man may easily underdose himself, and by exposing his microbes to non-lethal quantities of the drug, make them resistant. So these are words of Alexander Fleming in his Nobel Prize acceptance speech. So at the time of discovery itself, the problem of antimicrobial resistance was anticipated. And now it has become a full-fledged problem and a huge global threat. So the period of 1940 to 1962 is the golden era of antibiotics. That is the time when more and more antibiotics were discovered. And as we can see in this slide, it increases the life expectancy. So definitely it's a wonder drug, and it was a huge boon in medical sciences with the discovery of antibiotics. So this is the timeline. And we can say as gradually it progresses, now what we are having is the number of antibiotics being discovered or invented is becoming lesser. At the same time, the problem of resistance is increasing. So WHO declared antimicrobial resistance as one of the top 10 global public health threats facing humanity. And as already said, clinical pipeline of new antimicrobials is dry. So in 2019, WHO did a study, and they found out that 32 antimicrobial agents are in the pipeline of getting passed. But of that, only 6 antimicrobial agents are innovative. Rest all is like a Me Too drug. And by 2050, Asia will have 4.7 million deaths that could be directly attributed to antimicrobial resistance. With respect to India, 12 to 59% of E. coli are ESBL producers, 30% are carbapenemase producers. And Klebsiella pneumoniae has emerged as a highly resistant pathogen with up to 50% resistance to carbapenems and rapidly increasing resistance to polymyxins. Methicillin resistance in Staph aureus is seen up to 30%. And with respect to consumption, India is the largest consumer of antibiotics, 13 billion standard units in 2010. And from 2000 to 2010, per capita consumption is increased by 60%. So this is a slide showing the mortality pattern. In 2019 and in 2050, antimicrobial resistance is going to become a major cause of all-time mortality. So what accelerates emergence and spread of antimicrobial resistance? One is it occurs naturally over time. Second is misuse and overuse of antimicrobials. lack of access to clean water, sanitation, hygiene for both humans and animals. So that is going to cause increase in spread of multi-drug resistant organisms. Poor infection disease prevention control in healthcare facilities and farm. Poor access to quality, affordable medicines, vaccines, and diagnostics. So as a result of which, there'll be difficulty in controlling infections. Lack of awareness and knowledge, and lack of enforcement of legislation. That is, even now, people can go to medical shop and buy antimicrobials as over-the-counter medications. So it's not a simple problem. It's a major issue, and it involves a lot of aspects. One is human beings, that is the excess misuse and overuse of antimicrobial agents, where definitely we all have a big role to play, as we are the front runners of using these medications. Then environmentally, the pharmaceutical contamination, farms, hospitals, household and unused or expired drug contamination has to be controlled. Animal food, antimicrobial agents which is being used for human beings are used in animal husbandry for treatment and also as growth promoters, disease prevention. So this has to be curbed. With respect to Kerala, the major drivers of antimicrobial resistance in Kerala, one is use, misuse, and abuse of antibiotics in humans. Indiscriminate use of antibiotics in livestock and aquaculture, being used as a growth promotion and disease prevention agent. So as a result of which, there is spread of foodborne AMR pathogens. Recent studies have shown that colistin-resistant bacteria with MGRB mutation is seen in food samples. And Health Department has requested the Animal Husbandry Department for banning of colistin. And large number of inland fisheries are there. So again, they are using antimicrobial agents as growth promoter. And standards for tolerance of antibiotic residues in seafood, shrimp export has to be done. So this is growth promoter colistin sulfate premix, which is being used as growth promoter. So when we discussed with the Animal Husbandry Department in Kannur district, what they have told us, it is not being used in Kerala poultry, but is being used in Tamil Nadu. And I think our major supply is from Tamil Nadu itself. So once WHO recognized this antimicrobial resistance as a major problem, action plan was initiated. A global action plan for AMR was formulated in the year 2015. And a national action plan was formed in 2017. And Kerala, we developed our own action plan in the year 2018. And following, it was inaugurated in October 2018, but then COVID pandemic came and it took a back seat. Now, again, the program has been revived. So at all the district levels, we have an antimicrobial AMR program. Here in Kannur district also we have. And in this program, there is a recognized lab, which is the hub lab. For us, we have the regional public health lab, which is the hub lab, and spokes are the peripheral major hospitals from where the samples will be collected and sent to this lab. So in Kerala Antimicrobial Resistance Strategic Action Plan, we have 6 strategic priorities and focus areas. One is awareness and understanding. So today's session is part of this plan, that is creating awareness and understanding regarding the problem of antimicrobial resistance. Education and training. First, we have to educate and train doctors, staff, that is pharmacists, staff nurse, and all those who are coming in contact, that is hospital workers, so that we can formulate a plan. Then knowledge and evidence, setting up of laboratories and surveillance. So surveillance, like how I said, the hub and spoke model is being developed in every district for surveillance of antimicrobial resistance. Then another important aspect is infection prevention control. So that has to be done. Hospital infection prevention control, definitely it is needed. Again, in animal feed and food, that is animal husbandry department also, that has to be planned, and in environment also. So pollution control board also have a major role to play in antimicrobial resistance prevention. Optimize the use of antibiotics. Here, definitely, we all have a huge role to play. One is regulations, that is with respect to drug controllers, and the government has to make regulations. Even now, recently, health minister told that over-the-counter antibiotics won't be given as over-the-counter drugs, but still it is not being followed. Then hospitals and healthcare. Again, every hospital should have their own antibiotic stewardship program. They should have their own antibiogram and accordingly use antibiotics rationally. Veterinary and aquaculture, again, the animal husbandry department has to be involved in this. surveillance of antimicrobial use in the form of conducting audit of a prescription audit and all. Research and innovations, the state public health lab and higher labs research and innovative programs are going on. And finally, collaboration, that is public-private partnerships, also include the private institutions in this, and strengthen the disease control programs. So this is the same thing. So as a part of creating awareness, World Antimicrobial Awareness Week is celebrated every year from 18th to 24th November, where the activities are being conducted. One is to create awareness among general public also regarding antimicrobial resistance. Then AMR surveillance has to be initiated at all levels for 6 pathogens, that is E. coli, Klebsiella species, Acinetobacter, Pseudomonas aeruginosa, Staph aureus, and Enterococcus species. And mainly the 4 samples that has to be sent is blood culture, urine, pus or exudate, and respiratory specimens. So how are you going to combat this antimicrobial resistance? So what are the various action plans? One is whatever we have limited antimicrobial agents, plus the newer drugs are fewer and fewer. So we have to optimize the use of existing antimicrobials. Then second is prevent the transmission of drug-resistant organisms through infection control. And third is improvement of the environmental decontamination. So what are the fallacies in antibiotic therapy? I think we all have done it some time or the other. The thought of broader spectrum is better. Sickness requires immediate treatment. Failure to respond is failure to cover. So we change the antibiotic. Response implies diagnosis. So a person antibiotic is started, person is responding within 3 days. It implies that my diagnosis was correct. It could be because of a viral infection, which in its natural course has improved. When in doubt, change drugs or add another drug. More diseases, more drugs. Bigger disease, newer drugs. And antibiotics are harmless. So all of us at some time, we all have practiced this. So how are we abusing antibiotics? One is using it in non-infections. Duration longer than needed. Treatment of colonization or contaminants. And redundant or extra coverage. That is antimicrobial agents having the same spectrum we are using combined. So this was a survey which was conducted in a trust in US, but the reports are more or less same for us also. The scenario is same because we have not conducted any studies. So here what we see in the blue lines are the appropriate usage of antimicrobials and the red is inappropriate usage. So in case of bacterial infections, miscellaneous bacterial infections, we use it 100%, it is appropriate. Non-viral pneumonia, it is appropriate. Urinary tract infection, 100%, it's appropriate to use antibiotics. Middle ear infections, it's 87% appropriate, 13% it could be because of non-bacterial. Recurring conditions, 82% it could be appropriate, 18% it's inappropriate. Sinus infections, 66 it's appropriate. As it comes to pharyngitis, it's only 49% that is appropriate. Asthma allergy, it's 100% inappropriate. It's not needed. Bronchitis, bronchiolitis, 100% it's inappropriate. Middle ear infection, which is non-suppurative, again, it's not needed. Influenza, viral pneumonia, viral upper respiratory infection, all this, it's 100% inappropriate. Antimicrobial agents, antibiotics are not required for these conditions. So this is the study which was conducted in US, but I think more or less our situation is also the same. So what is antimicrobial stewardship? This is a long definition, is a coordinated intervention which is designed to improve and measure the appropriate use of antibiotics by promoting the selection of optimal antibiotic, the correct dose, duration and route of administration, which is leading to improve the patient outcome and decrease adverse events. So in a nutshell, we can say it's a right antibiotic in the right time, right dose, right duration for the right patient. So the goals of stewardship is, one is improve the patient outcome in the form of decreasing mortality, decreasing hospital stay, improve patient safety, reduce resistance, and definitely reduce the healthcare cost. So what are the principles of antimicrobial stewardship? First and foremost is make a diagnosis. So any case, first we have to ask, is it an infection? Try to define it anatomically, microbiologically, and pathophysiologically. definitely to do a test and define microbiologically in an OP setting, it's difficult. But with respect to its anatomical location and the common pathogens involved there, we can definitely make it, diagnose it as an infection or not, and whether it's a viral or a bacterial infection. Risk assessment, how likely that particular individual has chances of getting that infection. We have to rule out non-infectious mimics. Then take appropriate specimen culture, blood, sterile body sites, deep pus. Don't culture swabs and tips. Then whether we have to determine whether we need to start an antibiotic either empirically or we can wait till we get a definite diagnosis. Avoid using third generation cephalosporins and quinolones in outpatients. And use antibiotics with high genetic threshold for development of resistance like nitrofurantoin, doxycycline, etc. Then regarding empirical antibiotic therapy, we start if we can reasonably predict the infection given the risk factors and clinical conditions. So if you think you're suspecting a bacterial meningitis, definitely we can start empirical antibiotic therapy even before getting a diagnosis. Then what is the source and likely pathogens? So for each infections, the different sources of infection that particular individual, and also the correct pathogens has to be identified. Then is it a life-threatening condition which needs immediate initiation of antibiotics? So we have febrile neutropenia, severe sepsis and septic shock, acute bacterial meningitis, commune-acquired pneumonia, ventilator-associated pneumonia, and necrotizing fasciitis. These are the few conditions which is life-threatening and we need empirical antibiotic therapy. Then we have to choose an appropriate antibiotic. So that is based on, in case of inpatients, based on the hospital antibiogram, frequently encountered pathogens, and antibiotic sensitivity profile. So WHO has given a WHO aware classification of antibiotics in the year 2017. It was given. So in that aware, we have A stands for access, aware WA stands for watch group, and RE is a reserve group. So access group, that is we can use it. That is the first line of antimicrobial agents which has to be used. Watch group are the antimicrobial agents which are having more and more tendency for resistance. And reserve is the group which has to be used only after getting a definite microbiological diagnosis. So in aware, in access group, we have amikacin, amoxicillin, chloramphenicol, amoxicillin clavulanic acid, ampicillin, cefazolin, cefalexin, cloxacillin, procaine, benzyl penicillin, clindamycin, doxycycline, gentamicin, metronidazole, nitrofurantoin, and sulfadoxine trimethoprim. In watch group, we have quinolones, third generation cephalosporins with or without beta-lactamase inhibitors, macrolides, glycopeptides, anti-pseudomonal penicillins, beta-lactamase inhibitors, carbapenems, and impenems. So an important point to note here is macrolides is a watch group of antibiotics. So azithromycin is one antibiotic which was misused to the maximum, especially during COVID pandemic. The reserve group of antimicrobial agents, we have aztreonam, fosfomycin IV, 4th generation cephalosporins, linezolid, 5th generation cephalosporins, tigecycline, polymyxin, and daptomycin. Again, linezolid has been written in capital letter because it's a drug which is available orally. So there is more and more chance of misusing linezolid. So it's actually a reserve antimicrobial agent. Next is we have to optimize the use based on the pharmacokinetic, pharmacodynamic parameters. Always use a full therapeutic dose. So this is just example of few therapeutic dose of various agents, and drugs for which we have to give loading dose that has to be given as for cholesterol, and adjust in renal and liver failure. Another important aspect of stewardship is de-escalation. That is, once we start an antimicrobial agent, especially with respect to empirical therapy, and patient starts improving, de-escalation is something which it's very difficult for all of us to practice. We just think that, okay, any of patient is becoming better, so why to change now and create problems? So somehow we continue with that. So de-escalation is definitely a very important aspect of stewardship. So modify the empiric broad spectrum antibiotic based on antibiotic susceptibility and patient status. We have to stop polymyxin and glycopeptides if there's no growth of carbapenemase resistant organisms or MRSA. Combination, you have to go to single agent, IV to oral route, and correct duration has to be given. So So this is the algorithm of antimicrobial stewardship. It's more or less what I have told. So once we start empirical antimicrobial therapy, clinical review and decision should be made at 48 to 72 hours based on the microbiology report, the patient status, and based on that, we have to continue further. And these are the few studies that have come out where regarding the duration of antimicrobial therapy, where it's told that shorter duration also has got the same result as using it for long duration. This is for a community acquired pneumonia, where minimum 5 days is enough, is what's told. Short course antimicrobial therapy for intra-abdominal infection, where 4 days has got similar efficacy as that of using it for 8 days. And partial versus oral IV antibiotic treatment for endocarditis, and oral versus IV antibiotic for bone and joint infection. So these are the various studies. So this is how we can start. It's only starting with small steps we can move forward. So we have a low hanging fruit model for antibiotic stewardship. That is, a low hanging fruit can be plucked easily. So that's what we have to start. So one is antibiotic prescription for inpatients have to be put under a bracket. And if WHO restricted antibiotics are prescribed, a need for the same has to be documented in the case sheet. That is, if we are starting a reserve antimicrobial agent, we have to write the reason for starting it. If de-escalation is not practiced based on susceptibility report, the reason has to be same documented in the case sheet. Double anaerobic coverage is redundant. If double anaerobic coverage is given, reason for the same has to be documented. Suppose meropenem is being used, then there's no need of adding metronidazole. Similarly, even with piperazine and tazobactam has anaerobic coverage also. So there's no need of adding metronidazole along with that. So the redundant or double coverage has to be avoided. And if antibiotics are continued for more than 7 days, reason for the same has to be documented in the case sheet. If surgical prophylaxis is continued for more than 24 hours, reason has to be documented in the case sheet. And if more than 2 antibiotics are prescribed, reason for the same has to be documented in the case sheet. This slide is little congested, sorry. So this is based on the WHO aware antibiotic. WHO has actually they have a book, WHO aware antibiotic book. I will pass it on to secretary and he will share with everyone after this session. So in that, for each infection, what are the various antimicrobial agents has to be used. But finally, it depends on our population, our susceptibility and the individual patient. That is always important. It's not, we are not treating the blood reports or the microbiology reports. It's the symptom and the patient. Based on that, definitely we can use whatever is we feel is correct. Okay, this is just a small guideline for that. So in that, for bronchitis, what it's told is majority of it is a viral infection. So there's no need of antibiotic. Acute otitis media, again, if it's serious, there is no need. And if at all we are using, amoxicillin is more than enough. Pharyngitis, again, no antibiotic. There's some criteria. There's a Centaur scoring for pharyngitis. So based on that, if you think it's bacterial infection, we can start the antimicrobial agent and we have to start amoxicillin or phenoxymethylpenicillin is enough. Acute sinusitis, mild disease, no antibiotic, or you can start amoxicillin or amoxicillin clavulanic acid. So in the bracket, it's written access. So these are the access antimicrobial agents we are using. Community acquired pneumonia, again, mild cases, amoxicillin or phenoxymethylpenicillin is enough. COPD exacerbations, no antibiotic care. And if you think it is a bacterial, amoxicillin is enough. Infectious gastroenteritis, again, no antibiotic care. Or if we are starting, ciprofloxacin can be started. Again, it's a watch group of antibiotic for acute bloody diarrhea or dysentery. Skin and soft tissue infection, mild, there is no need of antimicrobial agent. Or amoxicillin clavulanic acid can be used, which is an access group. Or cephalexin or cloxacillin. Urinary tract infection, lower amoxicillin clavulanic acid or sulfamethoxazole trimethoprim or trimethoprim or nitrofurantoin. So this is just a few examples that WHO aware antibiotic book, all infections has been covered. So conclusion, the therapeutic benefit of antibiotics should be balanced with the unintended adverse consequences. Inappropriate antibiotic use is associated with increased antibiotic resistance, adverse drug effects, and Clostridium difficile infection. Antibiotic stewardship is important for preserving the existing antibiotics and improve the patient outcomes. And antibiotic prescribing should be prudent, thoughtful, and rational. So we as doctors who are definitely using the antimicrobial agents, we all have to start thinking before prescribing, not only for the patients, even for us. If we get a bronchitis, I think as first step, we should start with us and not using an antimicrobial agent, just wait and watch and then proceed with it. Thank you.
Thank you very much, Dr. Latha, for that informative and maybe slightly scary talk. We will now be more careful when writing antibiotics. Comments and questions, please.
Abroad it's very difficult to get antibiotics over the counter. So then how come that they have such a high rate of MRSA there compared to, I think it's more than in India also.
Yeah, I think maybe it's because of the spread of MDR organism. That is, see, and misuse is another thing. So if we already have the MDR pathogens, and if that is getting spread among the, this was a study done among inmates of some trust who was staying. So maybe there is cross infection. So that may be the reason. Yeah.
The doctors. So regarding the resistance, etc., we cannot treat because somebody is coming with an antibiotic. We should have to either continue the antibiotic. If we are continuing the same antibiotic, they'll think that medical shops are better than us. So that's the problem. So the legislature is very, very important. One point. Other point is, in Western countries, there are some scheduled drugs that can be prescribed for only for certain doctors. All doctors did not, like in India, any medical practitioner can prescribe from amoxicillin to meropenem. So that scheduled drug should be reserved for, especially in Western countries, you cannot buy, you cannot, GP cannot prescribe even omeprazole. Thinking that before that endoscopy should be done. Before like that, the legislature and advocacy is more enough than creating awareness among the doctor community, because doctors are supposed to do that.
Yeah, actually, I'll just tell my personal experience. This antimicrobial resistance program in Kannur district, I'm the nodal officer. So after becoming the nodal officer, definitely I have changed a lot. So before starting an antimicrobial agent, I definitely think twice, and patients are like that only. They come and tell that, please give that antibiotic. Antibiotic. That is what they think. That is, if you start antibiotic, it clears fast. So definitely we'll have to work on that. We'll have to explain to them that it's a viral infection. Even if you start antibiotics, it's not going to improve. And suppose you get secondary infection. So by the time we have already used this antibiotic, so we can't use, you'll have to use higher drugs, which will be more costly. So I think it will take some time, but I think with awareness, once we are aware of the importance, I think we can just spread it to the patients. It's difficult, but myself, I was one person who was using personally for recurrent sinusitis, I was using antimicrobial agents that I have stopped for the past 4 to 5 months. And it's like it gets cured. So, but I think legislation definitely, but we all know legislation, how far it works in all aspects, including our hospital attacks. So that is one thing which will take time, but definitely creating awareness is very important. Among patients, it's very important. See, what mostly they do is old prescription of amoxicillin clavulanic acid they have. They just go and show that and they say, okay, I need this. And within 2 days, it becomes okay. It's because maybe it's just an upper respiratory rhinitis viral infection, but they think it's because of that. And every time they go and buy. So that definitely, I think the drug controller and the drug licensing agency, they can definitely do some inspection and all. And if a farmer, the medical shop, if they are supplying that, some fine and all can be given. So I think that provision is there, but it's not being done.
Yeah, Dr. Rakesh, disease consultant from baby. So one doctor from India went to UK, ophthalmologist. She developed some throat and fever. So she asked her HOD to give me some antibiotics prescription. The HOD said, I don't have privilege to prescribe antibiotics for you. You need to consult your GP. So somehow she got an appointment. Before that, she went to medical shop and asked for antibiotic. So they didn't issue. Then finally, she found the GP, and the GP took the history, and she said, "You don't require any antibiotic; just even is enough." Okay, so that's how strict the other countries are prescribing an antibiotic. They are respecting it as just like another drug. So we think that it is harmless. Now the recent data there are so many studies are coming after this advancement of computer science, data analytics, networking, and so one study has shown that if you happen to take antibiotics for more than a cumulative time of 60 days, between age of 40 and 60, you are more likely to die, around 1.2 times more compared to the people who didn't take antibiotics. Okay, the reason they're telling it that it interferes with the gut gut antibiotic. Okay, so this thing plays a very important role in immunity, cancer, etc., etc. So that if you take one course of antibiotic, the gut microflora is altered for 1 year. To take 1 year to regain the balance. So this is the latest data. Okay. Okay, and these antibiotics are produced by bacteria and fungi to use against them. Okay, if you dig out 1 kilogram of soil, it is said that you can isolate almost all antibiotics from the bacteria from the soil. So these bacteria know how to destroy these antibiotics. So if you expose the bacteria some antibiotic, immediately it will become resistant. It's a very natural thing that if you expose a bacteria, it will become resistant. Okay, so it is very easy to develop resistance. Now, one study has shown that it was done in Swiss tourist travelers. So, as soon as they start from Switzerland, they will take a stool sample, analyze the E. coli, and look for drug resistance. They will visit India. They will go back. They are not taking any antibiotics, not visiting any hospitals, nothing. They found that 25% of them get colonized with drug-resistant E. coli. Okay, so you don't have to take any antibiotics. Just come and pass through India. You will get resistant bug harbor in you. So that's how fast this thing spreads. Okay, so that's the importance of maintaining infection control in hospitals. You have to maintain strict hand hygiene. Otherwise, immediately, if you touch a patient, it is said that around 150 bugs will get into your hands. Klebsiella, whatever. It will easily spread to another patient, very easily. Yeah, maybe. Yeah. And Thailand has come up with an excellent antimicrobial stewardship program at community level. Okay, they started flashing huge billboards, notices that just rethink again before asking for antibiotics to doctor. If you have rhinorrhea, throat, you don't have to take antibiotics. So they came up with a large community level campaign, and they were able to reduce antibiotics like azithromycin, amoxicillin, the community level by around 30 to 40%. An excellent reduction in prescription. Okay, and we are all so many antibiotics are prescribed in viral infection. Suppose a patient comes with fever, rhinorrhea, sore throat, you have prescribed amoxicillin. And the day two, it has shown to be having some flu or COVID. Then you don't have to complete the course. There is nothing like completing the course. That is applicable only in proven bacterial infection. In a soft tissue infection, you have to give 7 to 14 days. Otherwise, if you are getting an opportunity to stop, you should immediately stop. Okay. So I will just tell one more instance. I had a patient with COVID. He was hypoxic. He was on oxygen. There was chest infiltrates. Counts were normal. So his wife was a nurse. He was working in Dubai. Okay. Now I have started in giving steroids and all. The nurse asked, "Why are what are the antibiotics you are giving?" So I said, "This is a viral infection. There is no need for giving antibiotics." Then she got really angry. Why you are not giving antibiotics? He is sick. He is on oxygen. I said, this is a viral infection. So I started him on steroids and all. Next day the count went up from 10,000 to 14,000. So, but the patient was improving. Then the sister became even more furious. The counts is now 14,000. Why are not giving antibiotics? I said, this is due to steroids. So the next day count went to 60,000. But patient was off from oxygen. So by the time I think she got convinced that whatever I am saying is making sense. And next day the count came down. So the moral of the story is you need not start antibiotics unless it is definitely you are sure that because it's annual drug, it can bring out resistance, diarrhea, so many complications. Thank you.
Any more comments?
Superficial, again, if it's superficial skin infections, you can use local application. Deep seated infections only need oral antimicrobial agents.
Any more comments? Vote of thanks by Secretary.
On behalf of the Kannur IMA, I express our sincere thanks to Dr. Latha for her excellent and informative talk on antibiotic resistant. And we should all follow the antibiotic guidelines in our daily practice. Also, I thank all members for attending today's CME. Thank you.
Meeting is adjourned for dinner. Thank you.